Hello everyone, welcome to my YouTube channel. Today I'm going to talk about compartment syndrome part 2 of the video. Before I start, there is always a disclaimer, and the disclaimer is the same in all my video. Now let's begin. Acute compartment syndrome, after confirmed by clinical examination and/or serial examination, emergency fasciotomy is indicated. Again, the 5 P's. Pain during passive stretch test or excessive pain despite adequate analgesia, paresthesia, whereby the patient will have a tingling or numbness of the affected nerve region, pallor of the skin, paralysis, where there is a loss of muscle function and pulselessness, but usually the pulse will be intact despite in compartment syndrome. Please remember that tissue survival rate in muscle for 3 to 4 hours, there is still reversible changes for muscle tissue. At 6 hours, there are already variable damage to the muscle. After 8 hours, there will be an irreversible changes to the muscle. For the nerve survival rate, at 2 hours, there would be a minimal nerve conduction impairment. At 4 hours, there would be a neuropraxia, and at 8 hours, there will be a irreversible changes to the nerve. What is the complication of compartment syndrome without treatment? It will lead to permanent sensory and motor deficit. The example is muscle will have a long-standing weakness. There will be a disabling joint contracture. There will be a chronic ulcer. Devastating myonecrosis and rhabdomyolysis. Risk of developing reperfusion syndrome, and with severe complication that cause sepsis that will lead to multi-organ failure, MOF, and even death. What is rhabdomyolysis? It is a myonecrosis on a massive scale with leakage of myofiber contents, including myoglobin, CK creatine kinase, and other proteins into the circulation. Myonecrosis is caused by two basic mechanisms. That is a mechanical injury and energy depletion. Failure of ATP-powered pumps allows the influx of calcium into the myofiber. Calcium activates the protease and phospholipase, leading to disintegration of plasma membrane, contractile filaments, and other myofiber contents. Patient will present with weakness, myalgia, and muscle swelling. In biochemical investigation, there will be an increase in creatine kinase, CK, increase in renal profile pictures, RP, that suggest renal failure. The urine will show a red brown color that indicate myoglobinuria. Management of rhabdomyolysis is diuresis by using a mannitol, diuretics, or intravenous fluid to increase the tubular flushing and eliminate the protein material. For complication of reperfusion syndrome, there will be an influx of myoglobin, potassium, and phosphorus into the circulation. It is characterized by hypovolemic shock and hyperkalemia. Patient will present in a state of fluid loss, shock, in metabolic acidosis, hyperkalemic state, myoglobinuria, and renal failure. Management for this patient is preoperative hydration, mannitol, and bicarbonate. Please correct the electrolyte imbalance. For surgical management of compartment syndrome, emergency fasciotomy is indicated. So what is fasciotomy? It is a surgical procedure where the fascia is cut to relieve the tension or pressure, commonly to treat the resulting loss of circulation to an area of tissue or muscle. It is a limb-saving procedure. This picture shows a cross-section at the junction of the middle and distal third of the leg. There are 4 compartments that is needed to be released during surgical fasciotomy. That is anterior compartment, lateral compartment, superficial and deep posterior compartment. In anterior compartment, it contains the deep perineal nerve. In lateral compartment, need to be careful due to the presence of superficial perineal nerve. In superficial posterior compartment, it contains the sural nerve. And a deep posterior compartment, there is the presence of tibial nerve. For emergency fasciotomy, there are 2 methods that are commonly used. One is popularized by Mubarak, double incision fasciotomy of the leg. Number 2, the single incision parafibular fasciotomy by Matsen. For one, double incision fasciotomy by Mubarak, the anterior and perineal muscle compartment are approached via an anterolateral incision. The superficial and deep posterior compartments are approached through a separate posteromedial incision. Technique for A anterolateral incision are a single long incision are made 2 cm anterior to the fibular shaft. Incision around 15 to 18 cm. Incision lies over the anterior intramuscular septum that divides the anterior and lateral compartment. A small incision is made in the fascia of anterior compartment, midway between septum and tibial crest. Fascia is then opened proximally and distally. Technique for B posteromedial incision. Make a single longitudinal incision 2 cm behind the palpable posteromedial edge of tibia. After reaching the fascia, we need to undermine anteriorly to the posterior tibial margin, thereby avoiding the saphenous vein and nerve. Fascia is then opened distally and proximally under the belly of the soleus muscle. Through the same incision, the fascia of the superficial posterior compartment is opened 2 cm posterior and parallel to the incision of the deep muscle compartment. The other technique for fasciotomy in the leg is through a single incision parafibular fasciotomy by Matsen. In this technique, it avoids the medial incision. It releases all 4 compartments to a single lateral incision. An incision is made from the fibular neck to the lateral malleolus. The lateral compartment is then opened up. The anterior skin needs to be retracted to expose the fascia of the anterior compartment. Please be careful to avoid the superficial perineal nerve. Posterior skin is then retracted to expose the fascia of the superficial posterior compartment, which is then opened. The lateral compartment is then retracted anteriorly. The soleus is released from the fibular shaft and retracted posteriorly, exposing the fascia of the deep posterior compartment, and then we release it or open the compartment. So how to confirm whether the deep posterior compartment muscle are released? It is by passively extending and flexing the great toe. We need to feel the tension of the FHL, flexor hallucis longus. For post-operative management of fasciotomy, good dressing procedure followed by delayed primary closure or skin grafting at 3 to 7 days post-decompression or once the edema already reduced or resolved. What are the complications that would present later after fasciotomy procedures? 1. Altered sensation within the margins of the wound because of accidental damage to the nearby skin or nerve. 2. Dry scaly skin with presence of scar tissue. 3. Pruritus. 4. Discolored wounds. 5. Tattered scars. 6. Swollen limbs. 7. Recurrent ulceration. 8. Muscle herniation. 9. pain related to the wound. 10. Detected tendons with loss of mobility in the affected joint region. Okay, that's all for today. I will continue part 3 of compartment syndrome by covering chronic compartment syndrome and other additional questions that is usually asked during my exam in the master program. I hope the video is helpful. See you in the next video. Take care and bye.